remember, is a pseudonym. It's not the correct MRN. This patient has prior imaging history, but the imaging history for our purposes starts here. It was a patient that was admitted for, I should get rid of these arrows. Maybe you need the arrows to see what, because the findings are kind of subtle, but admitted uncontrolled diabetes with a non-healing leg ulcer, and so was admitted for plastic surgery to basically handle the wound. But while they're in the hospital, I think also decompensating, being treated for sepsis, the patient starts complaining of abdominal pain, and these plain films were acquired. On the plain film, you can see abnormally dilated stomach with a large amount of content, some small bowel that's mildly dilated as well, and then more subtle probably for you, some gas markings over the liver that are linear and do not look like bowel. Also, very subtly, you can see linear gas markings outside and along the lumen of the bowel, I mean the stomach wall here. I don't know if you guys can make that out at all. So
yeah, we can see it. It's a good call, though.
Yeah, it was a good call. I mean, these linear markings here. So this was described as gastric pneumatosis, and this was described as mesenteric gas in the liver, and all of that's true. And here's the CT to prove it. So I'll show you. Here's the mesenteric venous gas. You can actually see almost a gas fluid level in the portal vein right there. And then this is large gastric content, and then the pneumatosis is a little bit easier to appreciate with a lung windowed image that I just had there. So they did endoscopies. I don't know why I can't scroll on this one now. It's being ornery again. I probably have to. They found that the stomach was full of ingested contents, and that the wall of the bowel. Let's see if I can get the wall of the bowel did show signs of ischemia. Let me see if I can get that's the material that was in the stomach, and then these patches. Oops. What happened?
We can see.
All right. So this is the endoscopic images of ischemic wall. They don't really appreciate too much, at least I can't on the images. They did describe it, the pneumatosis, but they did see the gastric bezoar basically, and some ischemic changes in the wall. The patient was treated conservatively, so she had 2 endoscopies. It was a young woman. She had 2 endoscopies. They elected not to do an operative management of the gastric content. And the last notes I read, she was discharged because she was hemodynamically stable, and the bezoar was being treated by orally and via NG tube. Coke Zero was being administered, and apparently Coke somehow is acidic enough to dissolve gastric content, and it's a known treatment for bezoars, which I didn't know until I was reading the notes.
Makes it seem like we shouldn't be drinking it ourselves proactively. Right. But we have a question. So, one, did she have other signs of ischemia, like elevated lactate? Was she really sick?
No, she wasn't that sick. So I think maybe the ischemic changes in the bowel wall were only mild, and the pneumatosis, like pneumatosis can be, was probably relatively benign pneumatosis, even though it was gastric wall. A lot of times when we don't see a lot of pneumatosis in gastric wall, but when we see pneumatosis, it's always treat the patient, not the pneumatosis. And so that's kind of what they did here. So there was no draconian treatments required. The condition, I think, or at least that's what we believe, was due to diabetic gastroparesis and the stomach basically filling up with content and not functioning properly to the degree that maybe there was pressure ulceration on the wall or pneumatosis on the basis of, we never really know what causes pneumatosis, but anyway, it was pneumatosis. Go ahead.
One other possibility, I remember in residency, they told us that like the majority of gastric emphysema is not pneumatosis, but it's basically dissection from trauma from an NG tube. So she had an NG tube too. So she could have already been at risk because it was so stressed out. And then they put the NG tube and it like, sheared it. And then the air can easily dissect into the wall. And so it's not actually a sign of ischemia, but just of translocation. Okay.
Yeah, that's true. So maybe the NG tube caused a mucosal defect, and then the gas sort of collected beneath that defect and created, and then, we can see,
or even like a tiny ulcer from the pressure, because even like, during colonoscopy, for example, when they do a polypectomy and then all the air like dissects into the wall and even outside the wall, it's not from ischemia, it's from the air just dissecting through.
And it also kind of reminded me of a case of pneumatosis that was pretty extensive and was accompanied by a lot of portal venous gas, and yet that patient still did okay and wasn't bad. So even the presence of portal venous gas in the setting of pneumatosis can be not such an ominous thing after all. And
right, because if you think about it, the air in the wall can just go into the veins, and so it's just traveling air.
Right. So it's, you always have to call them and say, is this patient okay? Are they as sick as they might appear to be? And they're not always as sick as you think they might be.
It's interesting that the air is being translocated, but the flora is not coming with it. To cause the patient to become septic and stuff.
Yeah, they were treating, it's hard to tell. They were treating infection anyway, because there was, like I said, the wound infection and the sepsis related to that. So she was a unit patient, but now she's home or at least away from here and getting this Coke Zero therapy to her Bezor.